Good evening, everyone. My name is Scott Allen. I am the CEO for the Family Medicine Education Consortium, and I want to welcome you to tonight's Family Medicine Residency Showcase, where we're going to hear about obstetric care with Penn Madison Lancaster and Dr. Pam Vanenchek, but I will let her introduce herself in just a minute, and I will tell you a little bit about the FMEC. We are a catalyst, convener, and incubator, and I like to think of our primary objectives as threefold. One is that we help medical students learn more about family medicine and hopefully choose family medicine or primary care for their career. Two is that we like to help family medicine residents while they're in training, do scholarly work, do presentations, figure out what their career path might be. And three, we like to help family medicine residency training programs, faculty connect with each other, learn from each other, meet guidelines, present at our meetings. So that's a little bit about us. We are in the Northeast US. We cover 14 states and the District of Columbia, and there are about 220 family medicine residency programs in those 14 states and about 60 medical schools. We do an annual meeting each fall. Our annual meeting is actually next week, starting next Thursday. We bring about 1,000 people total, and that includes 300 to 350 medical students who come. If they're in the region, they come on scholarships. If they're outside the region, they can come on their own dime. But we like to have them meet family medicine residency training programs. We'll have actually 102 family medicine residency training programs at our meeting next week. We also do awards. We have learning collaboratives. We have lots of ways you can get involved with us. And there's a little bit about our meeting that starts next Thursday. So with that, I'm going to stop sharing my slides and turn it over to Dr. Vanenchek.
Hi, everyone. I'm Dr. Pam Vanenchek. I am the program director at Penn Medicine Lancaster General Hospital in Lancaster, Pennsylvania. I am also the president-elect of the board of the FMEC. So I am extra excited to be talking to you this evening. I'm going to tell you a little bit about our residency program. We'll talk a little bit about obstetric training in family medicine. And then I just wanted to present a few slides, a little bit about the landscape of OB and family medicine. And then really most importantly, we're going to open it up for discussion, either questions about OB, questions about our residency program, or even just family medicine residency training in general. We will be at the annual meeting in Philadelphia next week, so I hope to see you there in person. So Scott, if you wouldn't mind bringing up my slides, thank you. I am joined today by one of the assistant program directors of our residency program, Corey Fogelman, and then James O'Shea, who is one of our chief residents, will also be joining us. Next slide. First of all, a little bit about our residency program. We are the only residency sponsored by our hospital. Some people call this an unopposed residency. Frankly, I think that term sounds a little hostile. So I like to be a little bit more deferential. We have 13 residents each year, and we are a 3-year family medicine residency. We were established over 50 years ago. And our program is known for its very strong full spectrum family medicine education. We have strong adult inpatient education, outpatient, as well as maternity care. And I think it's really the strong maternity care component that distinguishes our residency from many in the Northeast region. Another way in which our residency is unique is we have 2 family medicine centers that all residents will practice at. So all of our residents get an urban experience at Downtown Family Medicine, which is in the city of Lancaster. The city of Lancaster is about 50,000. About 40% of the population of the city are Spanish speaking. About 12% identify as Black. And a few years ago, the BBC labeled us the refugee capital of the United States because our city is so welcoming to folks from other countries. And then in second and third year, all of our residents start their continuity practice about 14 miles south of the city in rural Quarryville at the Walter Ahmet Family Medicine Center. The inpatient work is done at Lancaster General Hospital, which is a just over 500-bed hospital, and that's where our residents do their emergency department, inpatient pediatrics, inpatient medicine, inpatient family medicine, and surgery experiences. And then the maternity care experience is done at a separate hospital that is part of Lancaster General. about 24 years ago, Lancaster General moved its obstetric and gynecology services about 3 miles down the road to Women and Babies Hospital. In addition to our strong in addition to our strong full spectrum education for everyone, we also have 21 areas of concentration. So residents may choose to do at least 200 hours of focus in particular areas of interest. It may be in HIV medicine, integrative medicine, sports medicine, adolescent medicine, street medicine, population health. We've recently added addictions and advocacy as well. And our residency program was awarded osteopathic recognition in July 2023. Next slide, please, Scott. A little bit about family medicine and maternity care and family medicine residency. As many of you may know, the ACGME, which is the accrediting body for residency programs in the United States, underwent a major revision of its requirements for family medicine residency programs. And as part of that, regarding obstetric and maternity care, the requirements say residents must have at least 200 hours or 2 months dedicated to participating in pregnancy-related care. There must be structured curriculum in prenatal, intrapartum, and postpartum care. Residents must care for pregnant patients in the outpatient setting, including prenatal care and medical issues that occur in pregnancy. All residents at any residency program must have experience with a minimum of 20 vaginal deliveries. And there should be continuity relationships with at least some of the deliveries. Now, for residents who want to seek the option to incorporate comprehensive pregnancy care, including intrapartum care and deliveries, those residents must complete at least 400 hours or 4 months dedicated to the care of pregnant patients and perform or directly supervise at least 80 deliveries. So those are the general requirements for all family medicine residents. Next, I'm going to do a little bit of talking just about family OB and family medicine in general. And then at the end, I'll talk about how we at Lancaster do our prenatal and deliveries. So the American Board of Family Medicine, which is the body that is the board certification body for family physicians. So back in 2000, about 23% of family physicians provided some type of maternity care. By 2010, it had drifted to less than 10%. And in more recent surveys, if you look at all family physicians in the country, only about 7% include deliveries as part of their scope of practice. Looking at graduates of residency programs, so looking at all of the graduates who graduated in 2020, so 4 years ago, 11% of all family medicine graduates were delivering babies, so a little higher than all total. And at our residency, about a third of our class of residents were delivering, so we're a little bit above the national average. When you're looking for a residency program, if you want to include obstetric and maternity care in your eventual practice, factors that increase the likelihood of a residency program graduates delivering babies include family medicine physicians who are preceptors, getting over 80 deliveries during residency, and programs where residents have greater autonomy in maternity care decision making. And family physicians with advanced training can perform C-sections. Next slide. So we in the United States are experiencing a bit of a maternity care crisis. Over 35% of US counties in the United States are considered maternity care deserts, where there are no maternity care providers or delivering hospitals in those counties. And so If you look at this map, the red counties are maternity care deserts. The yellowish orange are counties where folks have low access to care. Green have moderate access, and the gray have full access to care. And the states that are in the most trouble and have the highest percentage of maternity care deserts include the Dakotas, Oklahoma, Missouri, Nebraska, and Arkansas. 2.3 million reproductive age women live in maternity care deserts. And women who live in these areas are at or at significantly increased risk of having preterm births. And this data is from the March of Dimes, and in fact, it was just released this past Tuesday. Next slide. Over half of the US counties do not have a hospital that provides obstetric care. And so the counties that are shaded in darker blue are those counties where there are no obstetric hospitals. And this is from the American Hospital Association data. Next slide. And so over 36% of US counties lack an obstetric clinician. So lack an obstetrician gynecologist, lack family physician, lack certified nurse midwives that provide care. And 1.2 million women only live in counties where there's only one provider. And so that equates to about 2.5 million reproductive age women. So this means women are at much higher risk of not having prenatal care, having to travel greater distances to receive care. Next slide. And also the General Accounting Office just kind of chronicled how from 2004 to 2018, more than half of rural counties did not have services, and shows that many closures of obstetric facilities were focused in rural counties that were sparsely populated, had a majority of Black or African American residents, and were considered low income. Studies have also shown that there's a difference in the types of clinicians delivering babies in rural and urban areas. Specifically, family physicians are much more common in rural areas than urban areas, whereas OBGYNs and midwives are more common in urban areas. Next slide. ACOG has recognized that most rural counties do not have OBGYNs because they prefer to practice in urban areas where there's higher case volume and there's more access to other services. Family physicians provide a disproportionate share of the rural deliveries. As I already mentioned, a decreasing percentage of family physicians are providing prenatal and intrapartum care. Family physicians are really ideally suited to be delivering and practice in these rural areas because when they're not delivering babies, they can address all of the other patient concerns and take care of the children. Studies have shown that the maternal and child outcomes are similar if a family physician cares for and delivers a pregnancy compared to OBGYNs. Next slide. And this slide just further highlights that family physicians in rural counties have a higher chance of delivering babies than family physicians who practice in urban counties. In July 2023, HRSA announced $11 million in funding to strengthen the family physician workforce by supporting the development of 15 new residency programs in rural areas. And among those, 3 of those will be focused on obstetric training, specifically in rural communities. In addition to so other barriers to having family physicians training, there needs to be work done on improving credentialing processes at hospitals so family physicians can be appropriately credentialed, lifestyle concerns, and finding diversification of jobs, so that way more family physicians will be interested in practicing in these areas. Next slide. Oh, this was just a little bit on family physicians who do C-sections. And so from 2017 to 2022, of the almost 29,000 family physicians that responded to an ABFM continuing certification questionnaire, about 2% of family physicians were providing C-sections as primary surgeons. And interestingly, those 2% were more likely to be male, were more likely to be working in rural health clinics, and in counties that did not have OBGYN physicians. And so, again, family physicians can be an important part of the workforce to maintain and potentially expand access to rural maternity services. Next slide. So I think this is my last slide, and then we'll open it up for discussion. So let me talk a little bit about the obstetric training at our hospital. So all of our residents have 5 months of maternal child health, 2 in the intern year, 2 in the second year, and 1 in the third year. All of our residents take the advanced life support and obstetrics, or also course, in February of their intern year. We have 12 family medicine faculty, plus family physicians from the local federally qualified health center, and some community family physicians who are part of our call pool, who help to train our residents. In addition, we have a dedicated OBGYN group that was started and recruits physicians to specifically support the residency program. And in addition, we're working to hire 2 more to that group. We are very busy. Last year, our residency program delivered 1,184 babies. And those babies come from diverse practices. They come from our urban site. They come from our rural site. About a third of our deliveries come from the local federally qualified health center. And that health center is the primary home for a very diverse refugee and immigrant population. And then there are several private practices, some of which are in rural areas of our county. So we care for a very diverse swath of women. Next slide. Prenatal care, our residents do a lot of prenatal care in a traditional model, but pre-COVID, we had group prenatal visits in the centering pregnancy model. And so we fully intend to restart that. Certainly COVID put a pause on that for several years, and then due to staffing issues at our training site, we've not been able to implement that, but we do have plans to restart those group visits in the next year or so. We are very active in a research and prenatal care collaborative through the FMEC called Implicit. And this group is a collaboration of family practices, pediatricians, and residency programs that I think are up over 40 at this point. And this collaborative is working to decrease prematurity and low birth weight. We have a very active 4th trimester project in which we're focusing on women in that immediate postpartum period, where we're screening for depression, having early prenatal visits with moms and babies for screening for depression, making sure they have vitamins, making sure they have a family planning plan, and monitoring their blood pressure. So we have a very robust program. That said, not all of our residents, when they graduate, deliver babies, but our most recent graduating class, almost 50% of them were at least providing prenatal care, and 2 of them will be delivering babies. So we're very proud of that. So we are working to help improve some of the healthcare disparities for maternity care. So I think we will close our slides and open it up for conversation. And I'm going to switch to gallery view so I can see all your smiling faces. Yay, there you are. I'm going to have Corey Fogelman introduce himself.
Hi, Pam. I'm always inspired when I hear this talk. I think what I'm hearing is that family medicine can save the world, that we can go places where the rest of healthcare doesn't go, that we can fill in when in the wake of Dobbs' decision and the obstetric deserts that you described, that we're going to be the ones that are delivering that vital gynecologic and obstetric care. And so, I mean, I think if you're not inspired to, want to be a family physician by the opportunity to, provide that that care that people need, there are other reasons that we hold dear, and that is, if you go into family medicine because you want to provide pediatric care, the best way to continue pediatric practice in your own practice is to deliver babies and to have those newborns coming to your practice afterward. If you want to be an integral part of what makes family practice so strong, being a part of what the inspiring part of a person's life, you need to be there during those vital changes in a person's life. And there's no more important change than when a woman is pregnant and she's going through this exciting moment. You can be a part of that by helping her with her prenatal care and with her postpartum care, and then of course, like I said, helping watch her raise that baby and helping be a part of that family as they're raising those children. So I'm always excited that I can be a part of that part of my patient's life. And Pam, I think you should run for president. I'm happy to be your Tim Waltz. And our platform is that family medicine is the way of the future. So I'm sorry I talk too much, but it really is inspiring to be a part of this at LGH, where not only do we have faculty who are practicing obstetrics. Like Pam said, we have quite a lot of them, but we have a lot of community members who are practicing obstetrics. So they're role models for new grads and opportunities for you if you decide to practice in the Lancaster or Central Pennsylvania area. We can help find you a practice where doing prenatal care and obstetric care is a real life opportunity as a family physician. It's not just a dream. It's a real opportunity for your career. So I'll mute myself. Sorry, James, are you present? You want to welcome?
Yeah, he was having trouble with connecting to audio. Hey, James, we can actually see you now. Yay, if you can unmute, you can introduce yourselves. I just introduce yourself. There's only one of you.
Hey guys, I'm James O'Shea. Can you guys hear me? Pam, give me a thumbs up. Yeah, okay, good. So I'm one of the third-year residents at LGH. I don't know if anyone else said anything, but it's so nice to meet you all. I know, I think Pam gave a really good talk on our MCH rotation here at LGH. I'm one of the chief residents. If you guys have any questions, please don't hesitate to ask.
James, we did not go into detail about the MCH rotations. We kind of did a more surface level inspirational talk. If you wanted to talk a little bit about the rotations and what you do during your first, second, and third year, that would be great.
Yeah, sorry, my camera. I look kind of crazy right now. It's very difficult to hear anything on this phone. I think Zoom hates me today. But so our rotation, so there's a couple different things. So when we rotate it, we have a separate hospital called Women's and Babies Hospital where we do a lot of our OB care. And when you're there, it'll usually be an intern and then 2 upper years kind of on at the same time. And while you're there, you get to do everything. So you get to do everything from managing triage patients to come in at any point throughout their pregnancy. We also deliver, we manage L&D, so we manage all of our deliveries. We get to manage our own patients that we see in our continuity clinics as they deliver, which is really, really special. We do our best to make sure that when your patients deliver that you're actually on OB and you get to deliver your patients. So it's like a nice continuity experience. So you get to take care of mom and then the baby after, which is really nice. And then we do our deliveries for our FQHC. So that gets us even more experience. And then we're really involved in the postpartum care as well. We do everything until they're discharged, including circumcision. So we do it all. And then we have a really awesome like centering program, which I think Pam mentioned. So what that is we'll set up prenatal visits for you for every single clinic. And then you get to follow each pregnant woman throughout their pregnancy. And then so when it's time for you to deliver, then you'll get to be with them and deliver with them.
Yeah, so a lot of logistical effort goes into getting prenatal patients into clinics with residents who are going to be on OB during that time that they are due to deliver, be it 6 months down the road. We have those schedules laid out so that we can put those patients into the right clinics and they can follow along and have that continuity care. Like Pam said, we're very proud of our commitment to Implicit and the Fourth Trimester Project, both of which were started at LGH and have, like she said, spread throughout the Northeast and really throughout the nation. Those are research collaboratives and ongoing process improvement collaboratives that have helped us deliver more than just maternity care, but really whole family care to patients and families during both their prenatal and postpartum and well child care. And we can talk more about that during interviews or certainly this evening if folks have questions.
I'd like to open it up for questions. Clearly, Corey, James, and I are excited about Lancaster, so.
Hi guys. Ever hear me?
Yes.
Okay. My name is Ashish. I'm a fourth year at Dartmouth, applying to family medicine this cycle. I talked to the Lancaster program when I was at AAFP National Conference, and it's really exciting because I'm really also very much interested in this full spectrum family medicine, or at least like programs that are more full spectrum in family medicine. And so Lancaster is definitely one of like the top programs that I'm thinking about in the Northeast area. In terms of obstetrics care specifically, something that I was thinking of when I did my sub internship, and I'm wondering how Lancaster is like, is the complexity of patients. Like you guys mentioned that you deliver 1,100 patients, a lot of patients from FQHC who have like socioeconomic like like restrictions. And so when we think about like SDOH and things, like there will be maybe higher rates of gestational diabetes, gestational hypertension. So what is like the level of acuity, I guess, in terms of your OB patients, in terms of like how complex are they? What is like too much for you guys? What is like, oh, we do this so much that we get really comfortable by like our third year handling these types of patients?
Great question. I'll let James field that one.
Yeah, definitely. So I think we definitely have a very complex patient population that we care for. I think when I first started as an intern, I had a patient with preeclampsia, and then my senior was like, "Oh yeah, preeclampsia. Like it's a big deal, of course, but like you are so comfortable managing like preeclampsia with severe features. We've been seeing eclampsia. We manage postpartum hemorrhages. We manage you name it. We really do it here, which is nice." Just like a little personal side note, my wife is pregnant and she is going to be delivering tomorrow, actually. And she mentioned to me, she's like, it's nice how calm you are about all of this, because I feel like I've seen it all at this point. And then we also have opportunities to rotate with like our MFM specialist as well. So if you're looking for even more higher level, like complex care, you can rotate with them too. We collaborate with them when they're in the hospital, like we consult them and they come in. And then if there is anything like where the patient has to go to C-section because their strip doesn't look good or for whatever reason, like we're the ones usually making that call and we're the ones calling the OB. Like it's kind of our show that we're running there, which is really, really nice and special, I think. And not many programs have that opportunity. Like we work with the OBs very closely. It's like first name basis. Yeah.
Yeah, I absolutely agree. Our residents manage patients that any other hospital would be managed by OBGYN residents. And so we take care of very, very complex patients. And so the residents take care of all of the patients. So, you know, Corey and I, being family physicians, will take care of the more normal risk, although preeclampsia with severe features, diabetes, all of those things are very much in our wheelhouse. But the really complex things like the PPROM at 23 weeks or those kind of things, the residents are still taken care of, but we'll staff them with our OBGYN colleagues. Part of the reason, so we take care of very complex women, certainly lots of social determinants of health, but you know, we're literally taking care of women from all over the world. It's like really normal to have like 5 women in labor at one time and probably have 3 or 4 different languages being spoken. About 40% of the city speak Spanish, so a lot of Spanish, but we care for a lot of women from African nations, you know, from, you know, Caribbean, from South America. So really very diverse.
I think another benefit of our program too is that we have something called like OB protocols, which are like developed by residents with the help of faculty. So while like the complexity is certainly high, I feel like I always have the resources to find the answers to you know, new problems as they arise because we diligently to make sure that we have protocols for everything. And it's regularly updated by the residents. It's like part of our like quality improvement projects that we do. So I just think that's a nice plug for our residency too.
And I think managing complex patients, you know, there's a ton of learning there. And then thinking about to when I was talking earlier about family medicine practicing in rural counties, you know, if they are delivering in rural counties, they may not take care of all of that complexity in that rural county, but they need to identify it, need to be able to stabilize it until those women can be transferred. And, you know, in those rural areas, you'll be doing more deliveries that are more normal risk. So I'm sorry, I forget how you pronounce your first name. So I used to practice in New Hampshire, just down the road from Dartmouth in Claremont, New Hampshire at Valley Regional Hospital. So there, we did not deliver anyone who was less than 35 weeks, or if they, you know, preeclampsia or preeclampsia with severe features. That was something that we were transferring up to Dartmouth Medical Center. But until the ambulance or helicopter came, you know, we had to stabilize those patients. We had to identify it early so that way we can safely transfer patients to a higher level of care.
Thank you.
Hi, my name is Cindy. I also had a question. Kind of going off of that topic with helping care for women from different countries, I was wondering what are some of the more like social type of barriers that you've run into, and how does like what supports does the hospital offer to patients in this situation?
Corey, you want to take that?
Yeah, it's a great question. I mean, our patients have you name it, the barriers that they have, transportation, resources for during their prenatal care, resources afterwards. We have something called Healthy Beginnings Plus. It's a program in Pennsylvania. I'm not sure where you're located, but in Pennsylvania, our Medicaid program works closely with a group of nurses and social workers, and those Healthy Beginnings Plus advocates align themselves with Medicaid delivering practices such as ours to help sort of shepherd patients through their prenatal and even postpartum care. They practice with their patients for up to 2 years afterward. Not practice with, but continue to work with our patients for up to 2 years postpartum, and so we have a very close working relationship with Healthy Beginnings Plus. They see our patients actually with us in the clinic, and they help with food assistance. They help with, like I said, car seats and with clothing. They help us run our centering programs where we centering is a great program. I could talk for an hour about centering, but we're very proud to have started a centering program here more than 10 years ago, and we've managed to keep it going in some respects even through COVID. But we have plans to build it back up now that we have better resources. But at any rate, centering is a way of helping patients who have already delivered connect with patients who are primes, and they do a lot of education among the mothers. They do a lot of education, frankly, with our residents. They've taught our residents how to care for patients as well, and so they help us provide resources to patients, for any number of needs. So that's been very gratifying and educational for us as practitioners here in our community. And I think, a lot of programs have relationships like that with local resources. We're not unique in that way, but that is a very robust system here at LGH. In addition, we work with, like I think it's been mentioned, we work with the Federal Qualified Health Center in the area, and they have many resources for our patients. Our patients struggle with homelessness. They struggle with dental needs. They struggle with postpartum lactation needs, and we share resources with the FQHCs and with the other practices in the area. We have a very collaborative working relationship with several of the many practices throughout Lancaster and Central Pennsylvania to help meet the needs that our patients have. So it's every night I'm on Obstetrics. It's a new opportunity to meet patients where they are. I just was on call 2 nights ago taking care of a patient who had no insurance, and so we were helping her find ways to get her lab work accomplished in the most expeditious and cost-effective way. But you're always working with people regarding transportation and being conscientious about their needs. So it is gratifying and always like I said, an opportunity for a new experience.
Corey, do you want to talk a little bit about Vantage House? I realize we haven't mentioned that.
Yeah, I'm happy to do that. So I do a lot of things with the residency program, and one of those is that I lead a group of other faculty who work at one of our local women's shelter and rehabilitation center called the Vantage House. It's an Lancaster specific area, and it's very unique because it hosts women who are trying to do drug recovery. It's an inpatient center, which is to say that it's hosts women for up to 6 months in their facility. We go into that facility and deliver care within the home to those women and their children. They're allowed to have their children with them while they're doing their rehabilitation. They can be pregnant because we feel comfortable taking care of even those high-risk pregnancies, women who are on methadone and Suboxone. We take care of those women, and we see them, prenatal. They deliver at Women and Babies, and we deliver those babies for them, and then we take care of the women and their babies afterwards. We take care of them during their. We used to call it neonatal recovery. Now we call it Eat, Sleep, Console, which is when we see those babies through their drug recovery. We see the babies in the inpatient setting through their drug recovery, and then, as I say, postpartum and during their well child visits. It's a wonderful opportunity for us to help out with, a different pandemic that we're dealing with, and that is the drug pandemic. And it's very gratifying because those patients, many of whom are from outside Pennsylvania, they are moved to this facility because we're comfortable taking care of those women and their children, and because we're so comfortable with them, many of these women decide to relocate to Lancaster. So about 3 to 4 years ago, we were doing this so successfully as faculty that we started having our residents rotate there with us as well. So now the residents go into Vantage House 2, that's part of their psychiatric rotation, and they get to know those patients. They get to participate in some of the group care and some of the psychiatric care that those patients are undergoing. And then, of course, they're getting to know those patients who they will eventually be delivering and whose babies they may eventually be seeing in the inpatient setting. So it's again, it's a community resource, a community service that we provide, and an opportunity for our residents to further expand the scope of their care, or the scope of their practice. And I'm sorry I talk so much. I get kind of excited about all the different things family medicine can do. So I could talk for a long time, but I'll be quiet. Sorry.
Yeah, I had a quick question for y'all. I'm Jared. I'm a fourth year med student from Brady School of Medicine down here in North Carolina. I really liked how y'all were talking about the continuity of care. I love that. I think that's so cool that you get to follow those women as they're pregnant and be there for the delivery of their child. How often, even after like your neonatal period, do residents get to follow up with mom and baby after that as baby grows? Do you usually get to see, because I really love pediatrics, and it sounds like y'all have a great program between the OB and, kind of regular adult medicine. But would y'all say that it's a pretty strong pediatric training too, where you get that same continuity of care?
Yeah, I definitely think so. It's funny because when you do like the intake for our patients when they come into L&D, you're like, oh, who have you been seeing? And it's us, it's the residents, and they're like, who do you want your baby doctor to be? And they're like obviously you, and so it's really nice that you get to like continue that continuity, and you get to start building. Like even now, I have like generations of patients, even though I've been like a resident for 3 years. I think my longest one is 3 generations that I'm taking care of, like a mom, her baby, and then her mom on top of it, which is so cool. They're like, oh yeah, I'm gonna go see Dr. O'Shea, and then when you get to see them in the office, you talk to them about like, oh, how's your mom? How's your kid? How's everyone doing? And you know them really well, which I think is really special, which is awesome about, which is another thing that's awesome about our centering, how we like get to follow them, and then we get to take care of their baby, and that's how you like kind of grow your panel too within the program, because usually we do a pretty good job with taking care of our pregnant patients, and then they want us to take care of their babies too. And then I'd say we also have a really strong pediatric curriculum as well. You do a month as an intern and then a month as a third year, rotating inpatient with like our CHOP pediatricians, which is really great training. There's no like pediatric residents, like you're the pediatric resident. You get to do everything from LPs to admits, discharges, you name it, you get to do it there, which is really, really cool. And then I would say so we have 2 different clinics. One is like downtown in Lancaster City, and that is typically a little bit younger of a population. I have a pretty large pediatric panel there. I have one of the larger pediatric panels. I think my advisor was telling me I have like 30 or 40% was actually like pediatric panel. It was a pretty good amount. So, and then we have our second clinic, which is a little bit more rural, and that's typically where I get my like older chronic condition, like kind of patient there. But you have well child checks at least at downtown pretty much every clinic session. I can't remember the last time I didn't have a well child check, which is just like the annual visit for the kiddos. But yeah, we have a great pediatric curriculum too.
Yeah, and
since,
in addition, sorry.
go ahead.
So in addition, there are a couple of other months of pediatric care. We do have an outpatient uh, experience in pediatrics with and that's done with one of our local pediatric specialty groups, and then we have an inpatient nursery rotation that's kind of combined with our obstetric rotation, but during that time you'll do a lot of inpatient specific things in the nursery. We do circumcisions, and we do other procedures, but I've always I've always been very proud of what we do at LGH, and that is that it's like James indicated, it's not just pediatrics during your pediatrics rotations. There are so many children in our practice. Pam outlined how many deliveries we do. The second largest number of deliveries of any group, and that includes obstetric groups throughout Lancaster. In our hospital, we're the second most biggest practice by volume. We also are one of the biggest pediatric groups in Lancaster by volume, because even though we're family physicians, we wind up taking care of so many children because we're doing so many deliveries. So we have those babies coming to us. So you're doing pediatrics all the time. Even when you're not on pediatrics doing those rotations, it's really an opportunity to learn learn pediatrics within the scope of family medicine, and you wind up taking care of plenty of babies with a lot of different kinds of problems, and much of which involves pretty high level specialty care, coordinating with local specialists, moving patients around within the health system, and getting them the care they need, and often providing the care that they need. Like he said, at our rural practices, many of our patients don't want to go up to the big city, so they rely on the family doctors who take care of them. So we're proud to be able to provide that opportunity.
Yeah, we just had our annual program review. And so we spent a lot of time looking at data yesterday. And so looking at the age demographics of our residents. So all of our residents, so wherever you go, at least 10% of your outpatient practice is supposed to be pediatrics. For our residents, most of them were between 25 and some were even almost 40% pediatrics on their continuity panels. So, we really embody that. And I was just going to say, like James, when you've been a family doctor as long as I have in one place, so I've been here in Lancaster for 24 years. And so now I have 4 patients who I delivered them as babies. They were babies and now they're having babies. And it's so awesome, just this whole big circle of life.
That's awesome. Thank y'all so much.
Yeah, and I would also say especially while you're on your inpatient months of pediatrics, we work with a special group called the Clinic for Special Children. And that is a group that kind of deals with much more medically complex children. Sometimes you'll see like maple syrup urine disease, glutaric aciduria, those types of metabolic disorders that you wouldn't typically see. So you get that kind of experience as well. One of our graduates actually works with them now. So you can do whatever you want when you graduate from our program, which is awesome.
Yeah, I think that brings up, Lancaster County is known for its plain population, meaning like Amish and Mennonite. So that's another unique population of patients that we get to work with primarily at our rural site. But then, as James said, because of the more limited gene pool, some of these very complex, very rare disorders are very common in our county. And so that's how this clinic was started. And, patients go there and they have their genome sequenced and figure out what deletion they have and, get their special formula. And it's been so successful. Now these children, most of whom used to die in infancy, are living to be adults. And so that's where, Grace as a family physician, because it was started by pediatricians, because they were the ones. And so it's been great having, family medicine presence there. Other questions?
Are you guys able to hear me? Okay. My name is Neha. I go to the CUNY School of Medicine in New York. And it sounds like you guys have a lot of really awesome community outreach programs, and work a lot with community organizations to provide care. I was just wondering, what does mentorship look like between residents and faculty? And how are residents, I guess, able to kind of pair up with faculty and get involved in some of these projects in a kind of sustainable way?
Me unmute myself. Yeah, so when you come into the residency, you automatically get assigned to an advisor. And typically what we try to do is look at like maybe similar interests, like whether that be like clinical or even just like personal interests, just you know, something that you guys may or may not share. And then you're kind of grouped with that advisor all throughout residency. And then we'll typically meet, it's defined to meet twice a year. We have like semi-annual reviews with our advisors where we go through our progress through residency, things we're working on, things we're doing well, just like a very comprehensive review. And that's kind of blocked off into your schedule. So you can meet with your advisor to kind of go over everything with them. And then I also think that there's mentorship even within the residency. Usually there's, we'll try to set our new interns up with a senior resident who's kind of like big or like a buddy or whatever you want to call it, just someone that helps like guide them throughout residency. And that's like your contact point person throughout residency. And then we also have a very big resident like help group chat that we just like kind of everyone from interns to third years messages in and says like, hey, I have this weird lab result and I just don't quite know what to do. Like, what would you guys do? And we kind of all work through it together. So I think the mentorship is multi-leveled in our program. So it's like within the residents and then the faculty. And then even if, you know, just because you're assigned to an advisor doesn't mean you're not going to get help from other faculty members either. I know I've reached out to multiple different faculty members. We have like a stats, you know, attending. We have like a hepatitis attending. We have like with our faculty being so amazing. There's like everybody has their own little like niche special interest, and you can reach out to like the guy or the girl who is like kind of the specialist in that, which is really, really nice. I have pretty much all of the attendings phone numbers, and I'm pretty sure I've texted them all at least once throughout my time here. So everybody's an awesome place to be.
Yeah, I was going to say I have most of the residents in my phone as well. We text each other pretty regularly. If I have a project that I think residents would like to work on with me, I you know, I text the group and say, hey, who wants to join? And James, you know, correctly points out we've got very, very open communication between our residents and faculty. I think that's, you know, whatever residency you go to, you're going to be wanting to hear that they have, you know, a good collaborative, open relationship, open communication between the faculty and residents. That I think that's the mark of a good program, where people feel supported and embraced. Yeah, I work on you know, several different kinds of things, and I'm happy to have residents join me. And you know, we work for sometimes 6 months, year, sometimes several years together on projects, and it is really a lot of fun. And you know, I learn a lot. I think the residents learn too. At least they tell me they do. And you know, it's a real opportunity for me to build relationships with the folks that I think of as my future colleagues and my future, you know, practice partners. So that's, you know, that's the way I look at as our residents. They're just partners in the making. So you know, anyway, that makes it all the more fun every day.
Thank you.
I know we're getting close to the end of time. Any other questions?
Yeah, I mean, we do a lot of fun things at LGH. We have a very strong street medicine program where we work with our local homeless population. Several years ago, our residents noticed that we were, we have just like every urban center, we have a homeless population that needs urgent and vital care, and so we decided to start going out into the community and just walking the streets, offering care to people. We've done this in a very programmatic way, but we have built up a very robust program that is well supported by our health system. So we have, so our residents perform that care. We find it very innovative and exciting. We have a robust writing and scholarly activity network within our program. We write a lot of articles. We do what I think of as fairly robust research at our program. We've done randomized control trials of our own making. We've done we do process improvement projects all the time. LGH is constantly trying to make improvements, and we're excited when residents come in with new ideas. We try to run with those. If you're excited about doing family medicine and blazing new trails, we're excited to have people come and tell us about those ideas and hopefully share in the mission.
Not to double dip, but can I ask y'all one more question? Just in general, about the Lancaster program, like what's one thing each of you would say, just even on like the really tough days, because I can imagine how tough residency is, even on the flip side as an attending. What's something about y'all's program that even on the tough days kind of gets you through?
Yeah, I'm gonna say definitely the community, just like how much we like actually all genuinely like each other. We hang out. Like Fogelman at the beginning of the year had like a pancake run that we do like twice a year, and we kind of, and like the new interns came even before like intern year started. We just like extended the invite, and like I mean it's family medicine, like we all get along really well, and we all hang out like after work. One of my co-residents was literally in my wedding. We just get along really, really well. And I remember one night here, I think it was my AC died. And I think I texted Pam. I was like, Pam, who do I use for like an AC guy? Like, I have no idea. Like, what do I do? And I texted her. I texted a couple people. I was like, who do I just felt comfortable doing that. And I think it's the little things like that that really get you through the tough times, the hard hours, the complex patients. Like just having a really, really solid community is not something to overlook.
James took my answer. Yeah.
Yeah, I mean, I agree. I think, I work with my closest friends. I love hanging out with the residents, and many of them have become, members of my book group and members of my running group. And we have a great community here. I'm not from Lancaster. I moved here because of the residency program, but I love the city. We have a great, little culture within, Lancaster, and I'd invite you to come and at least interview and get a chance to be a part of it. We have a central market. We have a nice art scene. We have museums. We have beautiful. We have a lot of history here, and I love it so much. I wrote a children's book about it, and so it's an exciting place to come and visit. So I think it's just a lot of fun every day.
And on that note, we are doing all in-person interviews. So we pay for dinner the night before. We pay for a hotel room. You'll have breakfast. You'll have lunch. You have the opportunity to meet with residents, with faculty. You'll see the main hospital. If you want, you can also go to our rural center. So please remember us when you're putting in your applications in ERIS.
Thanks. Hopefully I'll get to see y'all in a little while.
Thank you.
Okay, well, thank you to the program and thanks everyone for joining. Have a great night.
Thank you all for joining. I really appreciate it.